Good afternoon, everybody. Welcome and thank you for joining us for this seminar today. This event is part of the 2022 Institute for Implementation Science Seminar Series, which features lectures with leading implementation science experts. Recordings of past seminars and registration for upcoming seminars can be found on our website, which will be linked in the chat shortly. Just a few announcements before we get started. This seminar is being recorded and the recording will be posted to our website after the event. All microphones are muted, so if you have any questions or comments during the seminar, please enter them into the Q&A box, as there will be time for questions towards the end of the presentation. I'll now hand it over to our Institute co-director, Dr. Maria Fernandez, to introduce our speaker. Thank you.
Thank you, Ricky. Hi, everyone. I'm Maria Fernandez, Professor of Health Promotion and Behavioral Sciences at the UT Health School of Public Health. And it's my distinct pleasure to introduce Dr. Geoffrey Curran. He's going to be talking to us today about effectiveness implementation hybrid studies, an overview and reflection on 10 years since their introduction. I'll remind folks that 2 years ago, he gave a talk through our institute also, and Ricky's going to put that link into the chat. And there you can see some of the basics of hybrid designs. And today he's going to focus on some advances since then. Dr. Curran is a medical sociologist and health services researcher with focus areas of diffusion of innovation in a variety of healthcare settings and predictors of treatment engagement and outcomes for mental health and substance use disorders. He's a professor of pharmacy practice and psychiatry at the University of Arkansas for Medical Sciences. For the past 20 years, he's been continually funded by the NIH, the U.S. Department of Veteran Affairs, and other funders to develop and test a range of implementation strategies designed to support the uptake and sustainment of evidence-based practices. Dr. Curran also has written widely on research design and methodology in implementation science. He's a director of the Center for Implementation Research, which is supported by the Translational Research Institute through the U.S. National Center for Advancing Translational Sciences of the NIH. The center is devoted to developing and testing implementation strategies across a wide range of service contexts, assisting with the implementation of practices within communities and training the next generation of implementation scientists. So I'm going to turn it over to you, Jeff. Thanks for joining us.
Well, thank you for having me. I'm going to get my screen up and going. Let's just make sure that everybody can see it. So are you seeing the full screen?
Looks great.
Yes.
Okay, well, great. Okay, well, thank you so much for having me. So this is these are the goals for today. So I'm going to be talking about this hybrid study idea. I'm going to give a relatively quick summary of these hybrid study types, kind of from the perspective of when we first released them about 10 years ago, and talk about things like when and why to consider them. I will go over these three hybrid types which we've proposed, and then in the second half of the talk, I'm going to talk about reflections from a recent working group. Maria, thankfully, was a member and is a member of that group, where we just wrote a paper, which we turned in a few weeks ago, offering some critique, adjustments, recommendations on these hybrid study ideas. You just heard some of this. Here's a little more of my background. I just want to highlight maybe a little bit more that I started doing work in this field in the VA around 1998 with their query program, which was at the time, and I think it is still, an innovative program which was funded by clinical dollars, where their healthcare system, really wanted to move the dial in implementing evidence-based practices and their own clinical guidelines, but also trying to have people do studies along the way to help them to figure out how best to implement these practices. So that's really it for my background. I always like to say, and especially for sort of wider audiences, that my focus in my work has been mostly in clinical settings, clinic-based studies, hospital-based studies, and more recently pharmacy-based studies. I've also been doing work for the past 8 or 9 years with our College of Pharmacy, and I've been focusing a number of, studies now on implementing evidence-based practices in pharmacy settings, and a lot of rural pharmacy settings. But it is critical, just to note, and I'll make the point a number of times today, actually, that the hybrid study notion was, really born from a group of us that, were pretty focused on doing work with clinical effectiveness, type studies and clinical interventions with a focus on clinical contexts. Okay. So the first time that we talked about these hybrid designs as such was from this paper in Medical Care, which was published in 2012. And I'm going to spend just a few minutes, talking about some of the arguments that we, made in this article and some of the background for where things are now. So just thinking back to when I first started in this field in the late 90s, we used to talk about a research pipeline. This one, is certainly clinically minded. And so when people talked about, all right, well, when do we do implementation research? There was this strong sense really that, well, we are kind of more on the right of this pipeline, and interventions, need to go through an efficacy research phase, do well there, move into effectiveness studies, still randomized trials, but in more real world settings. And, then after there's good effectiveness data, then maybe we start to think about how best to support implementation. And, this was certainly a siloed approach, and it certainly isn't the fastest way to try to move findings forward from learning what we know works to having most everybody do it. And so I often say that at that time, it kind of felt like a relay race, where clinical researchers or intervention researchers were, making interventions, they get it, ready for dissemination, and then they hand it off to folks like me, and then we have to figure out how to get folks to actually use it. So hybrid designs or hybrid studies were, really designed to kind of blend effectiveness research and implementation research, with the hopes of trying to speed this process. So why hybrid studies? Our first thought was, well, maybe we should try to hurry up, please. Maybe if we are able to blend intervention effectiveness and implementation research questions in the same study, hopefully we can save some time. It certainly felt like a bit of an irony that the way we were going about studying moving research findings into practice was, part of the reason why we thought that it was going so slowly. So maybe we also need to change how we actually do the research in order to try to speed things up. Maybe we don't have to wait for perfect effectiveness data before moving into implementation research and trying to figure out ways to help implement these interventions. Maybe we can backfill, for lack of a better term, effectiveness data on interventions while we are testing implementation strategies. If we are wondering about how intervention outcomes might relate to levels of adoption and fidelity, how are we going to know this without having data from these both sides? So again, some of the original rationale for looking into these hybrid studies where we were trying to make these blends. I always like to say that, people were doing these kinds of blends before we started to speak about them and write about them as hybrid studies. And our first paper tried to bring some clarity, direction, a few examples, and recommendations for how to move forward. In the 10 years since, we have certainly learned, that we had some hits, we had some misses there. And, we are trying to address some of the misses now. So this first paper focused on trial designs. And we called them designs, hybrid designs, and they were trial designs. And in the paper, we talked a lot about where you're going to randomize. In the years since, we have seen a lot of people use these concepts in, non-trial designs. And we are certainly, favorable of that. We fully support that. And that is something that I will touch on later. So when I talk about hybrid designs and about implementation science, generally, I often try to use some fairly simple language, especially when, teaching to people, from a variety of backgrounds. So in the talk, you will likely hear me talk about the intervention, the evidence-based practice, the innovation as the thing. And effectiveness research on these interventions, really looks at whether the thing works, whether the folks who are getting it are better compared to getting some other intervention or nothing. Implementation research in very basic language, to me, is really trying to look at how best to help people and places to do the thing. Implementation strategies are often, kind of our agreed upon term now for, in very basic terms, the stuff that we do to try to help people and places to do the thing. And if I were to boil down implementation outcomes into a few simple thoughts, it's basically how much and how well that people do the thing. And so for these hybrid studies, by definition, we are blending research into how the thing works, but also how best to support people in doing the thing, or at the very least, trying to understand what people might need in the future, implementation strategy-wise, to do the thing. Okay. In that first paper, we proposed, and we still talk about, three hybrid types. And starting with hybrid type 1, this is much more of a focus on looking at intervention effectiveness. So it's more about testing the thing or trying to study how well the thing works on individual behavioral type outcomes. But we are gathering information on doing the thing. Oftentimes a determinant type analysis to try to understand implementation and context, barriers to adoption, and things like that. On the other side, hybrid type 3 studies are kind of the opposite of hybrid type 1. So there's a focus really on testing doing the thing, or trying to study the impact of an implementation strategy or strategies on adoption, on uptake, fidelity. But we're also gathering information on the thing. We're also collecting intervention outcomes, but those in this case are secondary outcomes. And then there's hybrid type 2, which by definition is a combination of trying to look at or test some intervention and some implementation strategy or strategies at the same time within the same study. Okay, so I'm just going to go over sort of a brief summary of these hybrid types. For the most part, I'm going to be relying on how we talked about them in the first several years of us talking about these types after the first paper. And then a bit later, I'll be talking about a few ways that we're talking about these differently now, and some other things to think about. So hybrid type 1, again, mostly focused on testing the thing or trying to understand how effective some intervention might be, but also exploring implementation related factors. So these studies are normally focused on intervention effectiveness, but there's often some implementation focused process type eval going on to describe the implementation experience during the effectiveness study. So looking at things that worked, things that didn't, barriers, facilitators. We might also look at how might the thing need to be adapted going forward for better implementability. And we also might start to ask questions about and to try to understand what might be needed to support people and places in the future to do the thing in the real world. Again, these hybrid types were first talked about in a context of clinical research largely. And as we'll talk about later, some of these same assumptions here for these types work better or worse in other kinds of research. So when might be a good time to do a hybrid type 1? Well, intervention effectiveness data might be limited here. So a real focus on implementation is likely premature. But these kinds of studies, offer a nice opportunity to explore implementation issues and to think about and to hopefully plan ahead for implementation and strategies which might be needed, either for, moving to rolling something out or to study those potential strategies in the future. Remember, all effectiveness studies use implementation strategies to support delivery of the intervention. We normally just don't call them that. And in the clinical type studies anyway, we know that some or many of these strategies used are not really feasible to support widespread adoption in the real world. Things like paying clinics, paying interventionists, paying for care, intensive training, frequent fidelity checks, some of these things which happen a lot in clinical trials, but we know that those processes don't really translate well to this thing happening in the real world. But we can certainly learn from the use of those strategies and possibly others during this effectiveness phase, which can help us moving to the future. I'm not going to talk about examples here today. In my prior talk, I actually did, but I just note a few strong papers here. Okay, next over to hybrid type 2. So this is a combination study of looking at an intervention's effectiveness while also trying to study the impact of an implementation strategy or strategies on uptake on implementation outcomes. So it's a dual focus study. We used to talk about these as an effectiveness study combined with an implementation study, which might be a study which might compare two or more implementation strategies. In some of our old language, we call these a dual randomized study, where for the intervention effectiveness side, there was patient level randomization, and for the implementation side, oftentimes cluster randomization, and then a second type of a type 2, which we used to call sort of the pilot version. But this often, was and still is with a lot of funded studies, a patient level randomized trial in the context of kind of a pilot test of an implementation strategy or set of strategies that are being used everywhere for the first time at all of the sites. So sort of, a dual arm clinical effectiveness study with a single arm implementation study. Those are certainly not the only options, and there's a lot of people who are doing hybrid type 2s with other kinds of designs, and I will cover that later. When might a hybrid type 2 make sense for you? It is pretty common for folks to look at a hybrid type 2 when intervention effectiveness data are available for this kind of intervention, but perhaps not for the context and or population of interest for your study, and you're in a situation where you already have some information on implementation determinants, and you're ready to test some implementation strategies. Here's just a few more considerations that are really helpful for a hybrid type 2. In a study like this, it's very helpful. Well, we would say necessary, really, to sort of have an explicitly described implementation strategy or package of them that is thought to be plausible in the real world. And that's a clear distinction from a type 1. Next, in hybrid type 2s, you always see some explicit measurement of implementation outcomes like adoption, like intervention fidelity. We also think it's helpful to try to be as clear as you can about intervention components versus components of the implementation strategy, to be to be as clear as possible when you can about these components of each side. This isn't always easy to decide or describe. For example, is delivering some intervention over the telephone more of a component of the intervention or implementation strategy? And there are folks who approach this, really in either way. So again, here's a few papers which you could look at to learn more. Moving quickly, a brief summary now of hybrid type 3. Again, we have a focus here on testing of doing the thing, of the performance of implementation strategies, and then we're gathering information on the effectiveness of the intervention. So the unit of analysis in these kinds of studies is normally at either the implementer level or clinic or system or place in a non-clinical study. And the intervention outcomes are secondary. Hybrid type 3s, in some ways they sort of came as a bit of a product of some of the work that was happening in the VA at the time, where as a system they were interested in trying to roll out interventions that really didn't have a lot of effectiveness data, and that is relatively common. And so it was hoped that these hybrid type 3 studies could help folks to understand how best to support implementation, but also feeding back effectiveness data. And also too, if we are interested in exploring how effectiveness might vary by level or quality of implementation, then it's critical to have these kinds of data from both sides. So some of the things to think about in trying to do a hybrid type 3, especially if it's going to be place focused. How many places do you have or do you need? Are you going to try to do a powered study comparing strategies? You are certainly going to need, a fairly good number of places. Certainly for hybrid type 3s, you have a lot of options available for the kinds of study design, research design that might work best. There's a number of resources out there to help you with that question, not only for hybrid 3s, but for all of the hybrids. And I list a couple of papers here. I also think it's important when you're writing a hybrid type 3 to be really clear about the evidence for the implementation strategies which you are trying to study. Remember here, these are the main interventions that you are trying to study, and it's critical to talk about the literature, of which there's an awful lot for a lot of the strategies, which we commonly test. It's critical to fully cover that information. And you also have to think about, from where you are going to get the clinical outcomes data. These kinds of studies are a lot easier to do if the intervention outcomes are readily available in an EMR or other data set. If you have to do primary data collection in these studies to get those intervention outcomes, for example, in mental health focused studies, that's often the case. It makes it harder to do these kinds of studies, and it can certainly up your time and up your cost. Here's a few examples of hybrid type 3s. I just want to note that a few years ago now, we put out a sort of a newish introduction to hybrid studies. And here's just a few thoughts from that effort. We were seeing that, a lot of people were using hybrid type 1s and hybrid type 3s. When we first talked about them, we kind of thought that they would be more special cases, or that one might kind of need to argue why one is doing a hybrid type 1 or 3, where it seemed to be turning more into a case where, these hybrid studies were, in some ways, becoming the default way of looking at effectiveness studies or implementation focused studies. And so, we were making the case here that, maybe for a hybrid type 3, maybe, one might argue, well, why might I need it, or why might I, not need one? But to, just kind of nudge folks to consider questions like, well, why wouldn't we want to have these patient level, individual level outcomes? And for a hybrid type 1 effectiveness study, well, why wouldn't we want to have some factor of the study looking at implementability outcomes? And, in the years since the first paper, we have certainly seen a lot of people, doing pilot hybrid type, 1 effectiveness studies. We even see folks integrating some of this kind of work into efficacy research. So, folks have been applying these ideas, really more widely than we had first thought that people might. And for hybrid type 2s, we made a recommendation that for folks who were thinking about hybrid type 2s, to build in a fail-safe, if you will. Almost by definition, in a hybrid type 2, people are using implementation strategies in support of a clinical effectiveness study of some kind. And if your implementation studies are not doing a very good job with helping, with adoption, with fidelity, you could compromise your effectiveness study, which you really should not do. So to try to build in time, data collection, to be able to iterate the implementation strategies if it is needed, if for some reason your hybrid type 2 strategies are not really working well yet, which does happen sometimes. Okay, so fast forward to today. So I'm showing you photographs of the team members that have been working together with me as well, to try to think critically on hybrid designs studies, and to try to move some of the thinking forward. So these folks are Sarah Landis, starting from the top, going to the left, starting from the left and going to the right. That's Sarah Landis. Next is Sasha McBain, J.D. Smith, Maria, whom you all know. On the bottom row, Brian Mittman, Jeff Pine is next, and then David Chambers. So as I think I mentioned at the start, so this writing group has turned in a paper with this title. And what I'm going to do now is just share a summary of some of these newer thoughts. So this is a paper that was turned in to a special issue on hybrid studies in Frontiers in Health Services Research. So, clearly we aren't the only ones who are reflecting on using hybrid studies and offering critiques and recommendations for moving forward. So we structured our paper in the form of 5 questions, and these are questions which a lot of us who do these kinds of workshops frequently, we were getting these kinds of questions quite a bit. So we structured our comments based upon these kinds of questions, which we often get. So the first question is, well, hybrids, are they really designs per se? Well, I would say that it kind of depends on your definition, but I think it's clear that the initial paper's focus on trial designs was too limiting. As I noted earlier, the first paper talked about, where to randomize, and we have gotten a lot of questions in these workshops and things. Well, do these studies have to be trials? And the answer is no. There have been a lot of people who have taken the basic notion of hybrid studies, combining research questions from these both, from these two sides, and applied it to lots of different kinds of study designs, program eval designs, QI designs. And so as a result, we are recommending for the future to kind of drop the designs term, and to try to talk about these studies really more of, using the term hybrid study or hybrid approach. This might be the second most common question asked. Well, which hybrid type should I use for my situation? And so a few years ago, a subgroup of this current working group worked on a series of questions which we hoped would be helpful for people to work through with their teams to try to help them, land on the best hybrid for them. So we used to have 5 questions in our current working group. We've called it to 4. And the first question is, well, what is the nature of the effectiveness data on your intervention, your thing of interest? If it's very to moderately strong, and if you have the sense that the intervention really doesn't need to be adapted for your new study, then we recommend considering a hybrid type 3 or hybrid type 2, depending upon how much you expect to adapt the intervention, and that's the second question. But if you have mixed results or missing results or missing strong results, we recommend considering a hybrid type 1 or a hybrid type 2. The second question, how much do you expect the intervention will need to be adapted for where you want to study / use it? A little. Consider using a type 2 or a type 3, and it's pretty common for people to have that adaptation and process as a step or as an aim in the implementation focused project. That's very common, especially for a hybrid type 2. If you think that you have to adapt the intervention a lot, we highly consider people or think it's a good idea for folks to think about a hybrid type 1 or a hybrid type 2. Okay, so there are 2 more questions. Number 3, how much do you already know about implementation determinants for the intervention in the context of your interest? So if you don't know much about those determinants, about barriers, facilitators, and if you also need to focus on effectiveness data, that's a pretty clear case for considering a hybrid type 1. If the effectiveness data are pretty strong and you know enough about these determinants to develop and select a strategy or strategies, then we think that you are pretty clearly in the hybrid type 2 or hybrid type 3 category, depending upon, again, sort of the nature of the effectiveness data and if you need to adapt the intervention. And question 4, how ready are you to evaluate real-world implementation strategies in your study? So if you're not at all ready, so we think that a hybrid type 1 study is indicated, and this will give you the opportunity to collect the determinant information to help you prepare for developing those strategies, but likely after that hybrid type 1 study. If you are ready to look at those strategies, but you also have to focus on clinical effectiveness of the intervention or intervention effectiveness, that's a pretty clear indication, we think, of a hybrid type 2 study. And if you're ready to test those strategies and your effectiveness data are strong and you don't need to adapt a lot, so we think that's a pretty strong case for a hybrid type 3 study. Remember, you don't need to do a hybrid study. There are cases, for example, when some intervention has not yet been established as being safe, when that's probably too early for a hybrid. On the other end of the scale, you might not need to look at intervention effectiveness and only focus on implementation. If, for example, you want to look at implementation strategies to support implementation of vaccines, you probably don't need to do a hybrid 3 and look at the effectiveness of the vaccines. Or you might be doing a study that's kind of pre-intervention, and you're only doing a study focused on implementation determinants, and so you don't really need to, do anything more than that. So that's not a hybrid either. Okay. We do think that it's very helpful to explicitly justify why you are doing a hybrid in any of your proposals, or if you've done one, to talk about it in your papers. Okay, question number 3. So which research design should I use, and by which hybrid type? Again, here I don't think there are any hard and fast rules, and the choice of a research design is certainly going to mostly depend, I think, on what your research questions are. And these research designs are not linked closely to any hybrid type, but as hybrid type 1 studies favor intervention outcomes at a person level, we see a lot that these kinds of studies have, when they have randomization, are at the individual level, or it's more of a person focused study. For hybrid type 3, these are studies which usually favor implementation outcomes at a place level. So a lot of these studies are clustered in some way or have a place level focus. And with hybrid type 2, you have a blend of intervention outcomes, implementation outcomes, and hence the relative emphasis of those in your study will tend to drive the design choice. If it's leaning more towards intervention effectiveness, then it might lean more towards a person level type analysis. If it leans equally, then you actually might have sort of a dual person level focus and place level focus in a number of ways. I also want to mention too, though, that it's distinctly possible and certainly common for people to use hybrid studies using observational designs, doing non-randomized studies, and using designs often used for formative or pilot work, like a pre-post design, interrupted time series. It's relatively common to see observational hybrid type 2 and or 3 studies in healthcare system or public health systems, that are trying to look at how a rollout went, and they have some intervention or a clinical guideline that is automatically being supported by a set of strategies, and they rolled it out using those strategies, that can be clearly a hybrid type 2 especially. And you see a lot of those kinds of studies. And, you also see, a good deal of pilot type work, post formative work to revise strategies, optimize strategies. So again, your research questions are very critical, to your research design. Luckily, there's a lot of published hybrid studies out there. So there's a lot of guidance here also. And remember, I always like to say this, that our research designs are, really only as good as our partners are comfortable with. So that is a guiding factor also, certainly. Question 4. So what have been some of the challenges with the hybrid typology, the, type 1, 2, and 3? Well, as I noted before, the typology was certainly set with a clinical research mindset. And the hybrid 1, 2, and 3 thing doesn't seem to work well for health promotion, public health type interventions, where there's not a lot of efficacy research per se. In these cases, folks seem to, commonly or always start with, real world implementation in community settings and with real world strategies, which have always been developed. So in some ways, a lot of this kind of work is kind of starting by default with a hybrid type 2. But that hasn't always been clear or easy for folks to navigate. We're also not really sure how the hybrid idea and hybrid types, fit for policy research. These hybrid types were shorthand really for indicating the relative focus on intervention versus implementation outcomes. And it's certainly the typology, really does not capture nuance well. We also note in our new paper that, not everybody agrees on what the thing is. And there are certain kinds of interventions which are, in one field studied as the thing, but in others, they might be more considered an implementation, a patient-facing implementation strategy. So it's not always easy to agree on these kinds of issues, and there has been confusion with folks trying to study these kinds of interventions and not really being sure about which hybrid type it might be, with interesting cases of, well, if we define the thing as this seems more like a hybrid 3 study, but if we define it like this, it's kind of more of a hybrid type 1 study. And obviously that is not helpful to the field. Still though, in our paper, we recommend still using this typology. We still like this notion of trying to signal to reviewers, to readers, what kind of study you were going for, where is your emphasis, what are your primary outcomes, and of what type. But when there is nuance happening, which is very common, folks can use language like, well, our study is consistent with a hybrid type 1 approach, even though it's not a trial, or there's no randomization. And then finally, we have been getting a lot of questions about, okay, well, our field is really concerned about studying implementation costs, and I think that makes a lot of sense. So in our paper, we have some thoughts here, on how people are able to do cost effectiveness type analyses across all of these hybrid types. You certainly can have implementation costs be part of a conventional cost effectiveness analysis, using clinical or quality of life type outcomes, but people are also doing cost effectiveness analyses of implementation strategies only, using, for example, changes in adoption, in fidelity, to set these effectiveness ratios. So, as really with all of what we do in our field, I think integrating costs into our studies, it certainly calls for a team sport, and to, it's critical to, seek professional help here. There are a lot of studies in the past 2 to 3 years, protocols and things, which share how people are going about studying the implementation costs in their papers, and I highly recommend to seek those out. Okay, so this is it. So this is my last slide. So our working group, certainly hopes that these thoughts are helpful to people as they consider if, when, or how to use a hybrid study. Thank you for your attention, and I'd be happy to answer questions or hear some comments.
Great. Thank you so much for a fantastic talk, getting feedback and comments and the questions about people enjoying the talk. Have some questions that people have put forward, and I'm gonna go ahead and ask you the question, but then if the person wants to elaborate, we could take you off of mute, just you can raise your hand. So the first question is by Prajakta Adsul. And she says, you mentioned an important point about effectiveness researchers still using implementation strategies to deliver the intervention. Mm-hmm. What are some suggestions you may have to disentangle what goes into the research and what is relevant in the real world? Any methods, examples that you can share?
Well, I mean, I think it's important. I think it's most critical in a hybrid type 1 study to try to document all of the strategies that are being used, and to use that opportunity to try to, get perspectives from folks about explicitly which of these strategies might be workable in the future and which might not, and which might need to be adapted. I would say that in the clinical effectiveness world, I think there's less of a bar that you're trying to reach for a hybrid type 1 about, having these strategies be possibly feasible in the real world. But as you work your way forward to 2, I think that you are definitely wanting to work harder, do more developmental work to try to develop and use those strategies which you and your partners think have a chance to work in the real world. So I mean, I think it kind of depends on where you're coming from. It's I might argue that when it is possible for people to try to develop and use strategies which might be feasible in the real world, I think that that's always better. It's always a head start, but there are clearly, times, and I'm on some hybrid type ones now where, that just isn't really possible. And that's not the research question. They are really more in the area of, can this intervention work, as opposed to, does this work in the real world? And so again, your research question is really going to, help, or questions will help guide some of these decisions.
Thank you. I'm going to ask another, I think, related question by Michael Stanicki. It's our team is currently doing a hybrid type 1, while also working closely with our clinical sites on implementing various strategies, gathering data on fidelity to strategies, and the effectiveness of the strategies. We plan to report on all these outcomes. Have we moved into a type 2 or type 3 territory? Do we still call our study a type 1?
So I think that's a great question. And my gut reaction is, it sounds more like a type 2 to me, or at least for some of the strategies, you are taking more of a type 2 approach. I hear, so I am working with a K awardee now from an institute which shall be not named. And they have their R01 written. They shared it with the project officer, and they know where it's going to go, like to which committee member. And they said, I know that this really is a type 2, but I think that this committee might be a little more comfortable in this case with a type 1. You might want to shade it type 1, even though it might have some type 2 characteristics. And so in that sense, when the grant is being written as a type 1, but if it's funded, they fully plan on sort of nudging over into hybrid type 2 because they're simply ready to. And the K award looked at determinants. They have determinants. They are ready to name strategies. But some of the concerns about reviewers and things like that can kind of shade some of this too. But getting back to the question, it does seem like, at least in some areas, it's feeling more like a type 2 to me.
Thank you. Here's a question from Lisa Lederer. Don't the intervention and implementation strategy always interact, especially, for example, in psychotherapy? Do you have any advice on how we can keep these separate, draw a bubble around them?
I think that that's a great point, and I think that this is kind of, one of the, it's one of the potential indicators that, especially when you have a sense that the intervention components and implementation strategies are very well linked and you can't really pull them apart, that in some ways that's strongly or more strongly indicating a hybrid type 2 approach. I am not advocating for, sealing off these things necessarily. But I do think that there are times when, people can, not be as clear as might be helpful for reviewers, for grants or papers. And so it does make things, more difficult to have your study understood. But as I was saying, even in a hybrid type 2, the performance of your strategies, are going to be critical to whether you have enough people to be in the study, to have the power to show effectiveness. If the strategies that you've used don't produce the level of fidelity that you need to have a good study, you're going to have to mess with those to make sure that you still have a good effectiveness study. So they are certainly linked. I think a key distinction is how real world or not might those strategies be, which can help you to decide maybe if I'm really more in type 1 category or possibly more in a hybrid type 2.
Thanks, Jeff.
And Maria, I also just want to say that you think about this stuff as much as I do, and you are a key part of this new team. So if you want to chime in and help with your thoughts on any of these questions, please do, because your input is always helpful.
Will do, Jeff. You're doing great. The next question is from Kimber Richter. And it says, I'd love to hear some thoughts on across the spectrum of hybrid types 1, 2, 3 trials. How involved in the trial are the people who do or will do the thing? So examples or thoughts on different types or levels of involvement of the clinical implementers, not the researchers, in like type 3 designs, for example.
Okay, that's a great question. So I think in hybrid type 1, you certainly see more researcher control in the delivery of the intervention. And as one moves into type 2 and into type 3, I think that you see more of the intervention delivery being done by the folks that are likely to be doing it in the real world. There are some hybrid type 1s where that's happening also, but I think the more you go, from 1 until 3, the more necessary I think that is. For example, in the VA, they have a policy that every hybrid type 3 study, the intervention itself has to be delivered and paid for by the VA and by the local sites. So like it is going to happen as it would happen in the real world. Implementation strategies will be used to, train folks and support folks and facilitate and coach, but it is mandated that there is no researcher control there, and it has to come and even be paid for by the health service.
Great, thanks, Jeff. The next question is from Susan Alderman. I come from a strong clinical research background. How is this different from the feasibility question we add to all research protocols? Meaning, we ask, can this drug be given in the real world? So it seems these implementation designs are intended to answer, how can any drug intervention be moved out into the real world?
Yeah, I think that, as far as I know, all clinical trials collect some process data. Like I am doing a hybrid type 1 now in a PCORI study, and they are, and in the trial part, they are collecting data like recruitment figures, attendance in the groups, as these are family-run diabetes self-management groups. They are collecting fidelity of delivery or achievement of fidelity of interventionists that they are training at certain points. And I think it is common for all trials to collect those kinds of data. And that's great. And so in our hybrid type 1 work, we are using those data in a mixed methods way to try to help us to inform some of the qualitative stuff, which we are doing, going to the sites, interviewing every implementer, interviewing a lot of people at the sites where it is being tested. We talk with patients about the implementability of the intervention from their point of view. The hybrid type 1 determinants analysis is a process evaluation. It's just often being guided by an implementation determinant framework, which is pushing people to look at, I think, a wider range of potential implementation determinants than might be done in a normal trial process eval. And I think that's kind of the cool part. It's having people look at implementability and context and potential future strategies in a wider way, using mixed methods usually, and trying to make sure that we are talking with stakeholders and partners from all of the people who would have to be involved in doing the thing in the real world.
Yeah, and Jeff, you touched on this in your answer, but there was another question about what are your thoughts on implementation theories like CIFR and others, and the hybrid design typology. And I think you're sort of getting at that they guide questions around barriers and facilitators for implementation, and as such are likely most relevant to type 2s or 3s, but could also be begun to be asked even in type 1s. And would you agree with that?
Absolutely. So, I mean, I would say that in a type 1, it's very common to use a determinant framework, as we call it in our field, like CIFR, theoretical domains framework that's used a lot in Europe, to try to get an understanding of these kinds of determinants. Frankly, there are people who are using this same approach even earlier in developing interventions in the first place, more design for dissemination, type approaches. So as one moves to hybrid type 2s or 3s, you are explicitly going to measure implementation outcomes, like adoption, reach, fidelity. And so it's very, very common in those kinds of studies for people to use frameworks like REAIM, Proctor et al. Taxonomy on outcomes to help guide that part of it. And there's a cool logic model set from our colleague J.D. Smith, which helps people to conceptualize kind of the flow of this information and where some of these frameworks fit and where they might be helpful. In these kinds of studies, it is relatively common now for people to apply and be, guided by multiple frameworks, but each serve a function. And how many of those and what type just kind of depends on the goals and needs of your study.
Great, thank you. Another question by Catherine Hutchinson. When deciding whether to use hybrid or not, would you consider hybrid type 3 in a scenario where a single but large multi-site pragmatic RCT already studied effectiveness? Or with this level of effectiveness data, better to simply design the implementation study to follow up the effectiveness RCT?
Interesting question. I mean, I guess I would go to the point of, are you only trying to do what Greg Ahrens calls scale up, which means I am trying to get people to do the thing in the exact places and the exact people that were in this prior positive trial. And I suppose that in that case, where the settings, the population match the and hopefully big and excellent and awesome trial, then you might have an argument. If you're changing the kinds of context, you're throwing in some rural places, or you're throwing in some lower resource places, or you're expanding it in some way, or you're adapting it in some way, there could be an argument still for, hey, we don't have all of the effectiveness data for these kinds of people or those kinds of places, or because we've changed it some. So if it's possible, why don't we try to grab it anyway? And also, too, I will say, you need to talk to your funder too. For example, NIMH, they pretty much always want you to do a hybrid type 3. They don't look kindly on implementation only studies on mental health interventions. So they push you pretty hard to always do a hybrid type 3. They explicitly say, like, in their 5-year strategy plan, we always want clinical outcomes.
And Jeff, I would just add to your answer that it also depends on what we were talking about before, the extent to which the research team was involved in the delivery of that initial effectiveness trial. If it was a highly controlled study and you're still not sure about whether or not it would work when it's implemented with others, then it's worth doing a hybrid.
Absolutely, I think, yes.
So another question, this is from Esteban Fernandez. It says, given the distinction, the borders between type 1, 2, and 3 hybrid designs are not strong and a bit subjective. Can this cause problems when a protocol, a grant application, for example, is peer reviewed?
Yes, it does. I mean, I'm sure Maria could share some stories too, where you get a reviewer who says, well, you say it's a 2, but I think it's a 1. I think the most important thing to do is to explain as best as you can why you think it leans more towards like one or the other, and just be open about those thoughts. I think the more that you're able to share your reasoning, the more that you can draw up people into kind of where you got. I mean, as a reviewer on these kinds of things before, I've been somebody who has been, I understand that there are not these clear lines, and that the paper that that I helped write didn't give all the answers about what to do, and I'm not sure we can, but we are trying to be helpful. If I have reviewed a study that is an awesome study, and maybe they call it a 2 and I might think it's a 1, or I tend not to ding them for that, really, because I I want to see great studies happen that should happen. And some of these things can just be dealt with later on. And I don't see them as a deal breaker. And I hope that that kind of an issue is relatively minor, and it should be more about the quality of the study. But I've heard of people get dinged before. So, I mean, it does happen. Maria, any thoughts there?
Yeah, I think it goes back to that comment that you made, and I commented about that in the chat, about how sometimes we're not always in agreement about what the thing is.
Yes.
Right. And in health promotion, for example, when we're doing HPV vaccination studies, we might not think of the vaccine, for example, as the thing.
Right.
That's already there. We already have a recommendation. We might think of the multi-level activities that are done, or the intervention that you're using as the thing. And so you would need to define that. And I think that you're on more solid ground, the most solid ground, when you define and you say, this is what we're seeing as the intervention.
Yes.
These are the implementation strategies. And this is why we're calling it a hybrid, whatever, 1, 2, or 3.
Yeah. Yeah. I was just doing a workshop with a class yesterday or the day before at King's College on hybrid designs. And I do a workshop sometimes where I give people papers that are from funded studies, excellent studies, published papers, and they say that they did a hybrid study, but they didn't say which type it was. And I have people kind of use another set of questions to try to see if they can discern what they think it is most like. And in one of those papers, where they were testing a medication adherence intervention, I reached out to the authors and I said, well, what kind of, so I noticed and I knew them, so it was okay. And I asked them, okay, so what kind of hybrid do you think this was? Because I noticed that you didn't say. And they said, well, we disagreed. Because for me, the adherence intervention was the thing, so it's a type 1. But for someone else, the guideline to take med blank was the thing, and so the adherence intervention was a patient-facing implementation strategy. So they couldn't agree,
right?
So they didn't name it, but it still got funded, and it's a great study.
Great. So there's a question. Would you consider a feasibility study that also looks at barriers and facilitators, areas for adaptation, a hybrid study?
Is the feasibility about the intervention? If so, then I think that could very well be seen as like a pilot hybrid type 1, and there's a bunch of people that have published those kinds of studies and have used that language.
Another question says, we designed implementation strategies for a multi-level health promotion intervention, and in the process realized we needed to redesign the intervention. We are proposing to redesign it and test it along with the strategies, which may also require tailoring.
Yep.
And we are proposing it as a type 1, given the intervention redesign. Does this make sense? I think it's a type 2, but let's see what you say. Yeah.
Yeah, I mean, I would say that if any time you are looking at the same time at the intervention outcomes and you have some explicit strategies which you're also looking at their outcomes, I think you're sort of automatically in a type 2-ish category. And I think that this is why there's so many more, like in our never-ending scoping review, that this is why there's more type 2s than ones or threes, because I think a lot of people just want to do these kinds of combinations. They have some implementation strategies which they are ready to test, but they also need effectiveness data on the thing. And so they're doing a type 2, but it might not be randomized anywhere. And it might just, there's lots of different ways that you can do a look at both of those things. But, you know, that example certainly felt like a type 2 to me. And there's a lot of those kinds of type 2s out there.
Great. I think we have time for maybe one more question. So given the blurred lines of distinction between type 1, 2, and 3, are you better off not to label your study as a hybrid design and instead focus on the true design and let the aims speak for themselves?
That's a great question. I'll answer it like this. From the point of view that it is, you know, the 19th of October in 2022, and this is what I think now. So I would say you very much should make a distinction between your research design and what kind of hybrid type that it is, if you are going to state a type. I personally think it is helpful to try to state the kind of hybrid type that it is most like, because even just trying to answer that question is going to help you to be clearer about what your study is and isn't. And reviewers like to be told which type it might be most like, because I think it helps them with their mindset to be able to review it. And I think it helps paper reviewers too. So I think that you can be hedgy. So I don't think that you have to say, this is a type 2. I think you can say, based upon all that we understand about hybrid studies, this is most consistent with a hybrid type 2 for these reasons. And I think if you do that, I think I hope, I can't say that I think, but I hope that you would be safe.
Great, thank you, Jeff. And just wanted to point you to a comment and a link by Wynne Norton, that the science of implementation in health and healthcare study section at the NIH usually only reviews type 2 and 3s and not type 1, although there are some exceptions, and she provides a link there. At this time, I'm going to wrap us up. I did want to mention that Jeff and his team and JD Smith and our team at the UT Health Institute for Implementation Science are currently working on an online tool that's designed to help people figure out what type of hybrid design might be most relevant for them, or what type they're actually already doing, based on a series of questions with some caveats and comments throughout. So look for that. And at this time, I'd like to thank you again, Jeff, for a phenomenal talk. We've got lots of comments about how much people enjoyed this, and I always learn something when I hear you talk and hear you answer questions. So thank you so much. Ricky has posted in the chat also our remaining 2 seminars for this fall. So please join us then. Thanks, everybody.
Thank you for having me. It was really fun.